and go to screen share and hope it works. Okay, can you see the screen? Module 5 slows?
Yeah.
Okay. Okay, very good. I apologize for that. She'll settle down here in just a few minutes. I'm sorry. So I need to do this a little bit. Okay. So these are the we're in module 5, and we're in chapter, the first chapter 42. And we're going. These are the your module 5 slows that we'll be looking at today, or during this module. And they're pretty consistent with what's in the content. And we're going to look at differentiating Parkinson's, dementia, migraines, and epilepsy. And that's what we're going to do today. And look at identify contraindications and side effects associated with triptans, describe client education and nursing interventions associated with antiepileptics, such as valproic sodium and Vitoin. Compare and contrast findings associated with toxicity and tolerance to medications used with Parkinson's. Treatment options for the patient with Parkinson's with close attention to adverse effects, client education, and nursing manifestations. And then compare and contrast cholinesterase inhibitors and NMDA receptor antagonists used in dementia treatment. And that's basically what we'll be going through today. And so first thing I want to look at is care of the patient with problems with the CNS and the brain. And this is from your fact sheet. And before I get into that, though, I wanted to go back to just to review a little bit about, this is just a video about what migraines actually are. So I'm just going to show this really short video, just sort of as a review.
Migraines are more than just headaches. They're pre-headaches, post-headaches, sensitivities, nausea, fatigue, and can even bring on food cravings. But most of all, they are painful and frustrating for those who suffer from them. For years, they were misunderstood, but now we know it comes down to two main things: your genes and your brain. To really understand why migraines are so much more than headaches, first we have to know what headaches are.
My name is Rashmi Halkar Singh. I'm a fellowship-trained, board-certified headache neurologist here at Mayo Clinic. I'm also the Headache Fellowship Program Director here at Mayo Clinic in Arizona. There's actually a huge book called The International Classification of Headache Disorders. It has maybe 300 different diagnoses of different types of headaches. So when we say headache, all we mean by that is pain above the neck.
And yes, migraines are pains above the neck, so they are headaches. But again, suffering from a migraine attack is much more than just having a headache.
The migraine is actually a problem of brain dysfunction. It's a genetic disorder, and it's very common. So by diagnostic criteria, you need to have recurrent headache, whether it happens infrequently or frequently, lasting 4 to 72 hours without medication. And then in addition to that, the pain has to have at least 2 of the following 4 symptoms.
The pain needs to be moderate or severe in intensity, and more intense on one side of the head. Throbs or pulses, and gets versus activity. To stay on theme, migraine is more than experiencing pain. You also have to have either a symptom in the language sound or nausea. fact, migraine attacks come in 4 stages, with a painful headache being just one of them. Before the headache stage, some people, about 1/4 of migraine sufferers, experience something called an aura. If someone has a visual aura, they will see light spots, jagged lines, things like that in their vision. Sometimes people will have a sensory aura as well, in which they'll have like a pins and needles tingling sensation up one limb. And again, this typically lasts 5 to 60 minutes and is typically followed pretty much immediately by the headache. But before that, migraine sufferers will experience a prodrome, the first stage of the migraine attack. This stage can last an entire day. Symptoms include yawning, concentrating, and breathing. Finally, after the headache phase is ended, a lot of my patients will tell me, doc, I have this like headache hangover. And that's what we would call a migraine postdrome. This is not fully understood exactly just yet, but we think it's probably a recovery phase within the brain. And they might feel just really tired or fatigued or still have trouble concentrating, just kind of still recovering from the whole episode. So when we think about migraine, those would be the 4 phases. Most of what we know has to do with the pain phase. And what we know is not a lot. It was once thought that migraines were caused by constriction and dilation of the blood vessels that supply blood to the brain. But we know that's not the case anymore. We know that migraine is actually a problem of brain dysfunction. It originates from the brain itself, and it's a problem of pain processing. And there's a whole host of different components involved in this whole pain processing abnormality. And because of that, there's lots of different genes involved as well. A few genes have been identified, but we're still learning more about them. So we know that genes are a part of migraines. We can be genetically predisposed to have these headaches. Researchers have identified a part of the brain involved with migraines, the lingering pain associated with them. Really, a lot of emphasis on migraine has to do with the trigeminal nucleus caudalis, which is something in the brainstem that's really important for pain processing. And when a migraine attack occurs, there are what we call trigeminal afferent third nerve endings that also become activated, and they will release CGRP. CGRP stands for calcitonin gene-related peptide, and when released, helps pain continue, resulting in a long, drawn-out, painful migraine headache. Now, how this exactly works is still unknown, but the correlation between CGRPs and migraine headaches has actually led to better treatment options for patients. For the first time in history, we have preventive treatments designed to treat migraine based on what we know as to what happens in the brain during a migraine attack. And a lot of research has shown us that if you use CGRP in a patient is susceptible to having migraine, you can trigger a migraine attack. And if you block CGRP, that reduction in CGRP levels correlates with migraine improvement. So based on that information, we've been able to develop some new medications. So, this is a really exciting time in the migraine world.
So I just wanted to kind of go over that review, and we'll go back to our
is this all stuff that's going to be on test 5, not test 4?
Test 5, yes.
Okay.
Exactly. All this is test 5. And the one So the one difference that the video pointed out is that I think in your text, because it was in the original test, that the cause of migraines has to do with vascular changes in the brain, and I changed that just to reflect that it is abnormalities in the brain and genetics that are involved in causing migraines. So we'll go over that when we do a little bit of review, but I do want to point that out, that that is one difference. Probably what you're being seen in your textbook, I imagine. So as pointed out in that video, there are migraines are recurrent episodic head pain that serves no protective purpose. Sometimes when we hit pain generally is the reason we have pain for is just to indicate, there's a problem here or there, and we need to do something about it. So pain can be very diagnostic. It is usually on one side of the body. And it is, of the head, and usually related to that is nausea, sensitivity to light or noise or even head movement. So it's a little different than just a regular. Now, one thing for this housekeeping type thing with the Zoom is that if you're not speaking, you need to mute the computer because we can hear everything that's going on where you are. And sometimes it can cause kind of static and difficulty for people to hear. So just realize if you're not muted, we hear everything. You know, there are many factors involved in migraines, but at least we are doing much more research now and getting more of a handle on what it is. Not sure I can okay, sorry. Now, so the vasodilation followed by brain tissue inflammation, that is not where we're going for the test purposes for this course. So just want to emphasize that. Sometimes there is an aura, and as you know, probably from your study of seizures that you've had, an aura is something that's kind of lets a person know that maybe they're going to get a migraine, as well as perhaps gives them some kind of clue. So it occurs immediately prior to the migraine. It can be a sensation like they see something differently. They kind of sense that they're going to have one. There are treatments that can alleviate the pain during this phase if they're present, and not everybody has these. So, and sometimes they can even try acetaminophen or NSAIDs at this time. In my experience, when I've talked to people with migraines, this wasn't extremely helpful, but you know, this is something that you might want to know. The other thing are triptans, and they actually are associated with symptoms by alleviating serotonin receptors in the cranial arteries. So it deals with serotonin, and I do have a handout that I wanted you to look at here. This is from WebMD, and it does say that triptans can help with headache, pain, nausea, vomiting, and the sensitivity to light and sound, which is very disturbing for people. And they work by, again, you know, manipulating serotonin in the brain. Serotonin is the hormone that actually, neurotransmitter that makes you feel good. And there's several different kinds. And the side effects of these are dizziness, dry mouth, feeling heavy in your arms, legs, chest, feeling sleepy, flushing, muscle weakness, nausea, skin reaction. If you take the shot, tightness in your throat, and tingling sensations that usually go away. These are the people that should not take triptans. Basically, if you have any cardiovascular disease, problems with your liver, diabetes, stroke. It's important to know. So this is just some more information about that, but it does deal with serotonin. Now basically this is sort of the same thing that we just went over. It should be taken, it's very important that it should be taken as soon as the migraine begins. Once it gets a hold of the person, it can be more difficult for these drugs to work. And side effects that are normal are the tingling and hot sensations, and that usually improves. And it's important that, some people are on SSRIs, that is a type of antidepressant, and they shouldn't be taken with this because the SSRIs actually increase the serotonin in the brain as well. So if you get the, if you take both of those plus St. John's wort, which is, as you know, a supplement that some people take, it can lead to serotonin syndrome, which can be quite severe. We also don't want this to be given during pregnancy. So the other thing that we want to kind of look at are seizures and epilepsy, as well as the other aspect of this. And as you know, again, want to show you just a little video about, just a short video about seizure, about epilepsy, which is actually more complex than it appears. And there's a little advertisement in the beginning.
On our YouTube channel, you'll find a limited
We can't hear the video when you mute.
unpredictable seizures. A seizure is a period where cells in the brain, or neurons, are synchronously active, or active at the same time, when they're not supposed to be. Now, when I say neurons are active, I mean that they're firing, or sending a message using electrical signals relayed from neuron to neuron. And if you look at a neuron under a microscope, each electrical signal that passes through it is really just ions flowing in and out through protein channels. The way this ion flow is controlled is through neurotransmitters, a type of signaling molecule, and receptors. Neurotransmitters bind to the receptors and basically tell the cell to either open up the ion channels and relay the electrical message, called excitatory neurotransmitters, or close the ion channels and stop the electrical message, called inhibitory neurotransmitters. During a seizure, clusters of neurons in the brain become temporarily impaired and start sending out a ton of excitatory signals over and over again. And these are sometimes said to be paroxysmal. These paroxysmal electrical discharges are thought to happen due to either too much excitation or too little inhibition, which are kind of two sides of the same coin, right? The main excitatory neurotransmitter in the brain is glutamate, and NMDA is the primary receptor that responds to glutamate by opening ion channels that let calcium in, a positive ion that tells the cell to send signals. Some patients with epilepsy seem to have fast or long-lasting activation of these receptors. On the flip side, the main inhibitory neurotransmitter in the brain is GABA, which binds to GABA receptors that tell the cell to inhibit the signal by opening channels that let in chloride ions, which are negative ions that tell the cell to inhibit signals. Some patients with epilepsy seem to have genetic mutations in which their GABA receptors are dysfunctional, and so they aren't able to inhibit signals. In addition to potentially having a primary genetic cause, though, these receptors and ion channels might be affected by all sorts of things like brain tumors, brain injury, or infection. Whether it's a decrease in inhibition or an increase in activation, when groups of neurons start firing simultaneously over and over, often noticed by others as obvious outward signs like jerking, moving, and losing consciousness. But also be subjective experiences that are only noticed by the person experiencing it, like fears or strange smells. It all depends on which neurons in the brain are affected. People with epilepsy experience recurring episodes of some form of seizures, and we can start grouping the seizures by the region of the brain that's affected. When the affected area is limited to one hemisphere or one half of the brain, or sometimes even a smaller area like a single lobe, we call it a partial or a focal seizure. These seizures can be subcategorized by whether someone remains conscious during the seizure, which is called a simple partial seizure, or whether someone has impaired consciousness during the seizure, which is called a complex partial seizure. Simple partial seizures typically affect a small area of the brain and can involve the person experiencing strange sensations like hearing or tasting something. It can also involve jerking movements in specific muscle groups if the neurons controlling those muscles are affected. If the jerking activity starts in a specific muscle group and spreads to surrounding muscle groups as more neurons are affected, it's referred to as a Jacksonian march. Typically, the person is conscious, meaning that they're awake and alert, and will usually know that something's happening and will remember the seizure afterwards. Complex partial seizures, on the other hand, involve losing consciousness completely or having impaired awareness and responsiveness, so they might not remember exactly what happened during a seizure. Now, in contrast to the partial or focal seizure, a generalized seizure is where both hemispheres of the brain are affected. Sometimes the seizure will start out as a partial seizure and then quickly develop into a generalized seizure. And in those situations, it'd be called a secondary generalized seizure because a partial seizure came before it and was the primary event. Just like partial seizures, there are some subcategories of generalized seizures as well. One subtype is a tonic seizure, where the muscles all of a sudden become stiff and flexed, which can cause the patient to fall, often backwards. On the flip side, though, they can be atonic as well, where their muscles suddenly relax and become floppy, which again can cause the patient to fall, but this time forward. Seizures can also be clonic, where they have violent muscle contractions, also known as convulsions. Tonic-clonic seizures are the most common generalized seizures, where patients experience a tonic phase where the muscles suddenly tense up, followed by a clonic phase where the muscles rapidly contract and relax. Myoclonic seizures are yet another type, and are short muscle twitches, sometimes just a single twitch, but sometimes many in a short amount of time. Finally, there are absent seizures, where the patients lose consciousness and then quickly regain consciousness, generally with the only outward sign being that the person looks like they spaced out, like if they were walking, they'll suddenly stand still. The key for all these is that they involve both hemispheres of the brain, and patients lose consciousness either briefly or for longer periods of time. If the seizures do last for a longer period of time, like over 5 minutes of ongoing seizures or having multiple seizures without returning to normal in between, then it's called status epilepticus. And these are usually the tonic-clonic subtype of seizures, but it can also be caused by other types that don't involve convulsions. This situation is considered a medical emergency and can be life-threatening if not treated immediately. Due to the severity of these seizures, patients are often treated acutely with benzodiazepines, help enhance the effect of the inhibitory neurotransmitter GABA. Following a seizure, sometimes patients experience certain symptoms, like confusion, called post-ictal confusion, which means after seizure confusion. Also, patients might experience paralysis that affects the arms or the legs, usually just limited to one side of the body. And this is known as Todd's paralysis or Todd's paresis, and can last for quite a while, on average about 15 hours. And usually it subsides by itself completely after 2 days. The precise mechanism behind Todd's paralysis isn't currently well understood, but it's thought to be the result of temporary but severe suppression of activity of the area in the brain affected by the seizure. Typically, after a seizure is over, patients will have brain imaging techniques like MRI or CT scans, as well as an EEG, or electroencephalogram, which detects electrical activity in the brain. With patients who have just started having seizures, brain scans are used to find out if there are any anatomical abnormalities, like brain tumors or abnormal blood vessels that could be causing the seizures, both of which would be treated surgically. Because epilepsy can vary from patient to patient in the type, severity, and frequency of the seizures, diagnosis typically involves a variety of examinations and tests in combination with a thorough evaluation of their clinical history. Once epilepsy has been diagnosed, it's often treated with daily medication, the primary form of medication being anticonvulsants, of which there are a wide variety of options available that have different targets in the brain. So the choice is based on the specific needs of the patient, including factors like age, lifestyle, other health problems, and the category or subcategory of the epilepsy syndrome. Other treatment options include epilepsy surgery, where they'll remove what's thought to be causing the seizures, like a specific part of the brain or a tumor. Nerve stimulation might also be considered, where certain nerves like the vagus nerve are stimulated, which is thought to control seizures by influencing neurotransmitter release. Also, patients might adopt a ketogenic diet. This is a diet that forces the body to burn fat instead of carbohydrates, which produces ketone bodies, which are then used by the brain as an energy source instead of glucose. Although many hypotheses have been suggested for why this seems to reduce seizures for some patients, the exact mechanism isn't very well understood. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org.
Okay, so that was just a general review of seizures or epilepsy. It can be very difficult to diagnose epilepsy or seizure activity. And one reason is because it can manifest itself in many ways, as the video said. And, you know, so it can be very difficult. And even an EEG, just the initial EEG may show up no seizure activity, but there have been people that have had to go to various tertiary centers to get an accurate diagnosis. And sometimes they don't know why people seize, they just know they're seizing and they give them medication for it. And so it's never really diagnosed as why. On a personal note, my daughter's actually started having seizures and they're having real difficulty trying to diagnose what is actually going on with her. It can be very difficult, and generally when people present a certain way with the seizures, they tend to stay in that kind of way, although it can progress from one area to another, as mentioned in the video. And I just want to, review again. You have a handout that does show different areas of the brain which can cause different types of seizure activity. And this is something that I had neglected to show you a minute ago. This is a handout that just shows these are the classical 7 signs that you might be having a migraine. And we did go through this, but this is just a different way of mentioning it. One thing that I don't think was mentioned was neck pain. 69% of sufferers do tend to have neck pain during migraines, and sometimes they have sinus symptoms such as stuffy nose and watery eyes. So, many people, once they've had a migraine and realize how it feels, they are typically, they can identify that they're having a migraine versus just a different headache. So, go back to this right now. Again, this is what was in the video, and it is diagnosed as 2 or more seizures experienced by a person. Now, I do want to mention, while we're talking about seizures, that there is another kind of seizure activity not mentioned, and that's called a pseudoseizure. I don't know if you guys have heard about that or not. Basically, that is when someone does have the outside manifestations of seizure activity. The tonic-clonic generally is the type that's involved, but there is no organic cause for the seizure. And this is usually due to high anxiety levels, and usually depression is involved as well, but it's related generally to high anxiety. And the person is not doing this on purpose. It's not a fake seizure. It's just a pseudoseizure, and it's treated with anti-anxiety medications. And so, they're not doing it on purpose. They're not faking it. They're not trying to malinger. It actually is truly, they'll have all the symptoms of a seizure. And the other symptoms sometimes is people urinate during a seizure. And they have those symptoms as well, and it's uncontrollable. So that's something that kind of, keep in the back of your mind, that if there's completely no organic cause at all, if that's been ruled out, then sometimes they do look at some anxiety causes for this. And so go back to your facts page, which is what I always call these things. Many times, if true seizures can be controlled by drugs, it's important to keep the blood level of the drugs intact. That we don't want them to skip a dose, or they need to take it actually the same time every day to keep their blood levels up, and they usually do have blood levels drawn to make sure that they're where they should be. One drug at a time is introduced to assess effectiveness. Dosage may need to be increased or changed. So once you've added a second drug, then you don't know which is causing what. That's why we introduce one drug at a time. Excuse me. And so that's why, we generally, they will just start one drug at a time. And that's really for anything that they're trying to do. This is done in mental health as well. So because once you get 2 drugs, you don't know if it's the interaction of the 2 drugs that's causing the change or not. Again, must take on time to keep a therapeutic level. And with age, it's important that, just realize that you may have to have a change in dose. Clients may build up a sensitivity to drugs, so we need, they may have to change in dose due to that. But do remember they need to take this on time. Now, what we're going to do right now is, I'm going to go away from screen share for just a minute. And there's 4 templates that need to be completed. So what I'm going to do is I'm going to go to chat, and I'm going to write down the 4 drugs that need to be done. And we're just going to have 4 of you do one, so not everybody has to do them all. I honestly tried to put them in, and it wouldn't let me. So, let's do it. So we're gonna have to do them this way. All right, I spelled that wrong. So I'm just going to go down here through the alphabetical order through our roll and assign these drugs. The first one, this one, will be done by Danielle, Hannah, Baldwin, Bree, and Olivia. And the second one, this one, will be done by Rebecca, Marianne, Kate, and Heidi.
My roommate had to mail me my textbook since I'm in California, so I don't have it on me right now.
Okay, well, we'll let your other team members in. Do that. And then the third one, let's see. Will be Heidi, Sarah, Azili, and Luz. We'll do the third one, this one. And then the rest, Hashim, Coda, and Ryan. Did I skip somebody? Anyway, we'll do the last one. Okay, did I skip you, Ryan? Ryan will do the last one. So go ahead and we're going to take about 10 minutes or so and fill out those. I'm sorry about that. They're doing, I don't know what they're doing outside. But so go ahead and fill out those bid sheets, you know, things that are missing, and then we'll just, as when we come to these things, you guys can take the leadership in discussing those. Okay. So we're going to take a few minutes to do that. Let's take 10 to 15 minutes and do that. Okay, we're back now. So the first template that we're going to look at is phenytoin, which is actually Dilantin. And okay, this one is an anticonvulsant. And obviously, and I'm sorry about this, it does, it's important in limiting seizures, limit seizure prolongation by altering the transport. Is it to prevent, seizures and, and partial complex seizures as well. So, I can assign or someone can just speak up from the first group. What were the adverse effects that you all came up with, one of you came up with?
I have bradycardia and cardiovascular shock.
Okay. What
and
else? I'm sorry.
Leukopenia, thrombocytopenia,
Okay.
ataxia,
Uh-huh.
Stevens-Johnson syndrome.
Mm-hmm.
And I just hit the big ones. That's all that I.
That's fine.
There's
Okay. And Danielle, did you get any others? Okay. Well, some of those are, you're right. Some of the ones that might want to consider too are suicidal thoughts as well, and ataxia, as she said, and we'll go through that in just a moment. The nystagmus, where the eyes go back and forth, is another one that you might want to, consider, as well as hypertension. I believe you mentioned that. And also one to remember is gingival hyperplasia, where the gums actually get bigger, they grow bigger, and that's one that you sometimes see with this.
What was that one again?
It was gingival hyperplasia. So in other words, hyperplasia of the gums.
Okay.
And then one big one is what's called the DRESS syndrome, DRESS in capital letters. And it is just sort of it's a reaction, it's sort of an allergic reaction type thing almost, because it does deal with the eosinophils. And this causes, which, deal with allergic reactions. This is a type of white blood cell. And it does cause systematic symptoms and by exposure to certain things meds. And you want to remember this, that it relates, and the symptoms are rash, fever, inflammation of internal organs, lymphadenopathy. In other words, the lymph nodes get very large, lymphadenopathy. And then some hemolytic abnormalities, which is something that you did mention. You're going to have more eosinophils and thrombocytopenia, which means the platelet count will go down, and then lymphocytosis. So you're going to have, more white blood cell counts as well. So let me.
This is for fentanyl or Fedentin, right?
Yes. Yes. Mm-hmm.
Thank you.
And yep. And so let me show you. I'm sorry. So that's what's, that's the DRESS. So let me show you syndrome, and let me show you, okay, it's already up here. So ataxia, well, first of all, the DRESS syndrome, Miss and Pearls. Basically, this is just a handout that was provided by the course writer, that it is commonly, does affect the liver. That's why you're going to see a decrease in platelet count. And these new onset, you may have some proteinuria, hematuria, pyuria, and so these are things that you might encounter. But the DRESS syndrome is, it does cause increased eosinophils and lymphocytes and decreased platelet count. So thrombocytopenia is the name for that, and it is a reaction to some medications, including this one. So I'm not sure. So that's something that you'll want to remember. The other problem with this drug is ataxia, and some symptoms of ataxia can be lack of coordination, just not really be able to move well, abnormal eye movements. We did mention the stigmas, trouble eating and swallowing, so being able to coordinate, that movement, slurred speech, heart problems, tremors, and of course fine motor movements would be affected as well. Difficulty walking and poor balance, gait abnormalities. This person's going to appear like they're drunk, in other words. They're just going to be staggering around, can't really, do much of anything, and, this would be one reason you can tell the difference is the eye abnormalities, the way their eyes will move back and forth, and the fine motor movements. And but they're going to appear, pretty much like they're drunk. And so
I can hear you.
I'm sorry.
Oh, no, I couldn't hear you the last part.
Okay, they're just going to appear like they're drunk. In other words, the main difference might be the eye movements. They're going to have that, back and forth thing with their eyes that not be able to focus very well. And so that's maybe one problem with that. So contraindications, of course, if they have any sinus bradycardia, if they have any heart blocks, we want to use, really, be aware that with renal disease, that can be a problem. And so you can use those. One thing you want to remember is that several drugs may increase phenytoin levels, and that, I don't know why that keeps happening. And that antacids may decrease absorption, so you don't want them to take this drug if at the same time as they're taking antacids. So those are the two takeaways from this. And it is given PO and IV as well. Now we want to monitor for any behavioral changes. We want to assess and encourage oral hygiene and vigorous cleaning, because I do have that swollen gum problem. And so it'd be very easy for food or bacteria to get up under those gums. And so when we do give them IV, when it is given IV, we want to assess their vital signs to make sure their heart is not being affected, because again, it can lead to second and third degree heart block, so that's very important. Monitor their CBC, because we need to know the white blood cell count, the eosinophil, and the lymphocytes. And we want to look at their calcium level, their hepatic function, and it's important to, of course, monitor the serum levels of this. This drug is also called Dilantin, and so we do want, you might see it written that way. That's the brand name. So we want to look for any kind of toxicity. So we want to make sure that the level's not getting too high. Now, we again want to, look for any ataxia symptoms. That it's better to give with or after meals, so that they want to have food in their stomach when they get this, so they don't get any GI irritation. Monitor the IV site because it can be caustic if they're getting an IV. Generally, they're getting this PO though, and it may increase glucose levels. So those are the things that you want to, kind of remember there. Now, who would like to discuss some of the client education pieces for this drug?
Report rash.
Okay.
Avoid drop.
Go ahead, I'm sorry.
Avoid alcohol. If they don't want a pregnancy, use contraception. And notify your prescriber if she does become pregnant.
Mm-hmm. Okay, very good. The rash is so important because of the DRESS syndrome. That's very important. It's important, to not stop it abruptly. That we do want to make sure that, if they do stop it, that it's tapered off, because they're obviously going to start having seizures right away if they do stop it. Take it at the same time every day. And of course, it may cause drowsiness, dizziness. The other thing to remember, and this is true of other drugs as well, is that different brands of this medication may affect them differently or not be as strong. So they need to stick with the same brand of this medication if they possibly can. They do need to, apparently does affect the blood sugar. So if they are diabetics, it's very important if they do, check their blood sugar. And again, they should not take this with any antacids. It is apparently that will affect the absorption of this. And so I think that you guys have, pretty much covered everything. Did a really good job. And we'll go back to the fact sheet here. Again, check CPP and calcium levels, monitor for the therapeutic level, and that's what the normal therapeutic level would be, 10 to 20, and the toxic levels. If you are giving it IV, it is important to flush the catheter with saline before and after administration. And many times you should do that anyway for medications that you're giving. And these are some of the things that you do want to look for, which is what we said. Any kind of gastric distress or anemia or ataxia, nystagmus, and gingival hyperplasia. So, that's the swelling of the gums there. So, we're going to look at valproate now. Okay, this is anticonvulsant. It increases the level of GABA, so what it does is an anti-inhibitory neurotransmitter in the CNS. It does help with multiple seizures. And, not sure. You do want to...
I'm sorry, which drug are we on?
We are on this one, valproate.
Okay, thank you.
And we're going to look at suicidal thoughts, any agitation.
Gotcha.
Everybody okay now? Okay. Another thing is hepatic toxicity. And a very important thing to remember is pancreatitis. And we'll go over that in a bit. The DRESS syndrome, again, it can cause thrombocytopenia, as well as hypothermia, alopecia, loss of hair loss, nausea and vomiting. And we want to look at liver involvement or impairment. And anytime you have liver involvement, you can develop bleeding disorders. This is true for anything because it does decrease the platelets. So liver disorders, you always want to look, or impairment, you do want to look at, platelet bleeding problems. There are several drugs that can affect the therapeutic levels, and those would just have to be taken one by one if you do have a patient. You probably would want to ask the pharmacist if to look at drug interactions. When we start looking at drug interactions between several drugs, it's best to refer to a pharmacist, because you can usually look up one drug, two drugs are going to interact with each other. But if there's more than that, it really probably needs to be.
Wait, excuse me, which drug are we on again? I'm really confused.
Yeah, me too. I don't know which drug is it.
Yeah, I'm saying
Val-
too.
This is the
Yeah, me
valproate.
too.
Valproate sodium?
Could we see in the screen? We can see in the screen which one. Oh,
Right
okay.
here is what we're looking at.
Thank you.
Okay.
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 Okay. So, with that, we're looking at, according to our fact sheet, monitoring for signs and symptoms of pancreatitis, and monitor for CBC, platelets, and renal function, which is really important. So, yeah, this is just valproate sodium. Again, this one was completely filled out. I know it's difficult to read the way it has it set up. But the biggest thing is liver impairment, pancreatitis, suicidal thoughts, and agitation. And several drugs may affect that. And again, I would just contact the pharmacist about that. It is given PO and IV. And so we do want to monitor for any behavioral changes, since it can cause suicidal thoughts and agitation. It can cause pancreatitis. And the symptoms for pancreatitis are abdominal pain, nausea, vomiting, and anorexia. So you want to remember that the signs and the symptoms of pancreatitis are abdominal pain, nausea and vomiting, and anorexia. We want to monitor for the DRESS syndrome, which is fever, rash, lymphadenopathy, hepatitis, nephritis, hepatological abnormalities, myocarditis, and eosinophilia. So if you're giving this medication to someone and they develop a rash, what would you think the first thing you should do?
Notify the healthcare provider.
Right. And if you're giving that IV, you'd want to stop the IV. But yeah, notify, because this is a sign that they may be getting into this syndrome, and they're probably going to order several labs. What labs do you think they would order?
Liver, renal, CBC.
Yeah, right. Okay, so creatinine, a CBC, liver function test. Yeah, exactly, because we want to look at those things. And that would tell us, more about that. And, probably palpate their lymph nodes. So even if they just see a rash and or fever, but you do want to remember about the rash. And then you do want to monitor their hepatic function, like we just mentioned. And you want to monitor them for any GI irritation, that this should be given with food. So some of the client education related to this, again, is, and this is true apparently for all of the anticonvulsants, is do not stop abruptly. They need to be weaned off this medication. Very important. All these meds can cause drowsiness or dizziness. So it's important to monitor for any changes. The patient needs to be notified how to monitor for signs and symptoms of pancreatitis, but that's very important. And any abnormal bleeding. So why would they want to report abnormal? Why might they have abnormal bleeding?
Because low platelets.
Exactly. When you have low platelets, it causes abnormal bleeding, and when you have liver problems, low platelets, abnormal bleeding disorders. So that would be, obviously, if they already had that, that's one of the contraindications over here. And we don't want them to be taking this if they're pregnant, because it can affect the fetus. And of course, the evaluation is a decrease in fetal in seizure activity, obviously. So that. Check something out for this minute. Make sure I'm recording this. Okay. I'm sorry, I just had to make sure that I had turned on. Okay. So the other one is this drug right here. I'm not quite sure how to pronounce it. This is the same thing as Keppra, and I'm sure that if you're in practice and have dealt with patients who have had seizures, probably the majority, if they're being treated on an outpatient basis, is giving this drug. The other two, especially phenytoin, was used quite a bit in the past. But what I'm seeing from the patients I'm talking to, more are on this medication right here. And that medication, let me find the page number for that. In your little book, your little drug handbook, this drug is discussed on page 765. So the only thing as far as, so you will really want to read that because you'll need probably to know that information. For this class purposes though, you want to make sure that you do monitor the renal function carefully. And as well as, do not stop the medication abruptly as well. So that's something that you want to remember. So that is,
Ms. Ostrom.
uh-huh.
For this next test, could you give us a review for Module 5?
Yeah.
Okay,
Yeah.
thank you.
I'm going to do after this one, because we don't have the test, before we do test 5, I'll do, review. But for this, after this, we go over this, I'll just do since it's been a while, I might do, just, if you want to, just a brief review for the next test, test 4.
Okay.
But I might go over a few things if that's okay. But yeah, I will.
Okay, thank you.
Yeah. The slows are really good for this as well. The slows improve quite a bit. So yeah. Because I know it can be kind of confusing. So what we want to look at next is Parkinson's disease. And this is really kind of a complex disease. You probably have seen this in your, have you all studied these diseases in your adult yet?
No.
No.
No, not yet. I think it's after this test we're gonna start studying this.
So I'm kind of like one ahead, apparently, aren't I? I need to probably coordinate this a little better. But you did have this, did you study these kind of things in pathophysiology?
Yes.
Yeah, I just want to, kind of have a sense of, where you are and everything and all this. This can be quite difficult. Well, it can be difficult to, somewhat to diagnose. It's very difficult to live with. I have actually a brother-in-law that has this, and he has pretty much all the symptoms involved here. And as you can imagine, I do have again, do these short videos help you guys review the physiology and that kind of thing? Yes. Or not? You can just send me that in a chat if you like. I'm just hoping that these things will, kind of help. It just sort of seems like a way that maybe kind of review that before we, move on. So I do have one just about epilepsy. These are just like less than 4 minutes.
Parkinson's is the second most common neurodegenerative disease after Alzheimer's. The most visible features of the disease are slowness in movement, loss of mobility, and tremors at rest. also many often debilitating ongoing symptoms, some of which may present
Ms. Elstrom, I can see the video, or it's just the audio?
different types of neurons. However, which focuses on neurons in brain regions associated.
You can't see the video? Did someone say they couldn't see the video?
Yeah, I can see the video.
Yeah, no one could see the video, Miss Selstrom.
Oh,
Still on the fact sheet.
it's still on the back sheet? Um, now can you see it?
No.
Nope.
Are you having your breakfast, Arjun?
Now can you see it?
Yeah.
Okay.
Parkinson's is the second most common neurodegenerative disease after Alzheimer's. The most visible features of the disease are a slowness of movement, muscle rigidity, and tremors at rest. There are also many, often debilitating, non-motor symptoms, some of which may present before the motor problems. Parkinson's affects many areas of the nervous system and different types of neurons. However, which focuses on neurons in brain regions associated with the symptoms, notably the region of the midbrain called the substantia nigra factor. This region forms a major pathway in the brain that is critical for facilitating movement. Parkinson's dopaminergic neurons in the substantia nigra gradually die, leading to the malfunction of this pathway and the characteristic motor problems. Drugs, nasal are often used to treat these motor deficits, but are less effective over time. Deep brain stimulation may also be used to treat symptoms. However, no current treatment slows the neurodegeneration. A distinctive pathology in most cases of Parkinson's is clumps of misfolded protein within neurons. We believe are the most common type. A characteristic component of these is a misfolded protein called alpha-synuclein. These molecules can form small repeated units called oligomers, or longer fibrils. Mounting evidence indicates that toxic neurons play a key role in driving Parkinson's. Oligonucleotide that cells different types of protein-degrading machinery. Some evidence points to these systems being overwhelmed with the misfolded alpha-synuclein, a key factor in what kills the neurons. Parkinson's has also been linked to problems with mitochondria. Mitochondria provide cells with the energy to perform vital functions. They're highly dynamic and can fuse together or break up into smaller versions in response to a cell's energy demands. They can also be transported to areas of a cell that need them the most. However, in Parkinson's, these processes can be impaired, and mitochondria are unable to sustain proper neuronal function. As they become old or damaged, mitochondria are removed and replaced. Again, this recycling is thought to be disrupted in Parkinson's, leading to the accumulation of damaged, worn-out mitochondria. Another idea is that cells called glia surrounding neurons may play a role in Parkinson's. As dopamine neurons are lost, one particular type of glial cell called microglia will take the resulting cytokine, triggering an immune response. Once activated, it releases inflammatory cytokines to activate neighboring microglia, another type of glial cell called astrocytes. These activate microglia and astrocytes function in neurons. There remain open to drive the disease process in Parkinson's. What is clear is that with time, more areas of the nervous system develop pathology. And one emerging idea is that this happens through the transmission of misfolded alpha-synuclein. While While the multifactorial nature of Parkinson's disease progression might make it hard to fully understand, it does provide a number of potential therapeutic targets for slowing or even halting the neurodegeneration. For example, enhancing the clearance of abnormal proteins and blocking their transmission, improving the function of mitochondria, and targeting the neuroinflammation are all currently active areas of research.
Okay, that was just a short reading. Can you see this back page now? Yes. Okay, thank you. I don't know why that happened. I should be able to go from thing to thing and you see it. Were you seeing the other things before we were talking about the medication sheet? You weren't? Well, no wonder you're confused. Well, I'll make sure you see them from now on. So Parkinson's is neurodegenerative, as you know, and let me go to another handout just a moment. I didn't realize you guys weren't seeing those. So these are the cardinal. Can you see this? Okay. These are the cardinal symptoms of Parkinson's disease: tremor, rigidity, akinesia, brachinesia, not being able to balance is a really big problem, and postural instability. So, you know, they have a lot of, and also tremors, fine tremors, and, you know, I'm sorry?
Ms. Esther, how is bradykinesia or bradykinesia? How?
These are tremors, and also not being able to, and then as well as, you know, they're not able, their balance is off as well. Rigidity and tremors. And so I don't know, maybe giving you the wrong information about akinesia, but now that you mention it, it does kind of slow movements. It's as you move, like if you're trying to reach for something, the movement is kind of slow, that kind of thing.
Okay.
As well as, and these are some of the medications that we'll be going over. This is just a table. This kind of thing can make sense to people at times when things can. These are some of the medications that we'll be going over as well. And this is a classification of these medications and basically some of the common side effects that we have as well. So now I'll go back to our table here. So it's just a system that checks and balances. Basically, this is a decrease in dopamine, and that's what allows for these kind of movements. And it just they just don't, you know, secrete the dopamine to the receptors. So there's unbalanced levels of dopamine and acetylcholine, and it causes excessive excitation and prevents the person from controlling and initiating voluntary movements because they're tremors, they can't reach out for stuff. It also can affect the heart and brain and cause orthostatic hypotension. These people with blood pressure they can go into shock in, you know, just a moment's notice. And so I know my brother-in-law has been hospitalized many times for hypertension, and they have to work really hard to get his blood pressure back up. So this can be, you know, quite a bit of a problem. Generally, it is seen in older, you know, individuals, usually 60 years and up. We do treatment, of course, is to increase your functional capability. There's really no cure for this. There is some brain stimulation surgeries that have been done that have been very helpful for symptoms for some people. They are on long-term therapy, so they may develop, again, toxicity or tolerance, as we talked about. If they do develop toxicity, it can cause changes in their cognition. They can start hallucinating, you want to remember this, and get delirium. And of course, the drug may not be as effective because it's just so toxic levels. It's not being helpful. The other things is that tolerance, the effects don't last as long as previously did. You know, like they had helped their symptoms for a while and then now it doesn't. It does. So basically we do sometimes reduce the drug dosage, change drug or frequency, and sometimes the drug holiday up to 10 days. When you're on a drug that can controlling neurological symptoms many times, and this is true for other things, even like do study in narcolepsy, and people with narcolepsy take drug holidays as well. But just not stop taking the drug, maybe like over the weekend or for a few days, and then and then when you start taking the drug again, it seems like it reset it. Kind of like turning off your computer and turning it back on. Anytime you have a problem, that's what the IT people tell you to do. But it's that kind of thing that you sort of start resetting what the drug does. And so sometimes that can help with this kind of with tolerance. Many of the drugs, those that are dopamine agonists, just mimic the actions of dopamine. And so it's just sort of trying to do the same thing that dopamine does. They're usually most effective in the first 3 to 5 years of use. So you want to remember that. And they do decrease the incidence of the dyskinesias, of the movement problems, and loss of response, and decrease incidence of loss of response to the drugs. Of course, adverse effects of the medication can be orthostatic hypotension, hallucinations, sleepiness, and drowsiness. So, it's sort of a risk-benefit type of thing, as we've said before with drugs. They can cause many adverse effects. One just has to identify, is this benefit worse, more important to me than the adverse effects. The other thing that you have to remember as we talk about drugs is that the way people react to drugs is very individual. And the symptoms of Parkinson's is different from person to person as well. So what will work really well for one person won't work well at all for somebody else. So that's something that you really need to kind of try to remember about that. Now we're going to hopefully try to look at the levodopa, carbidopa template in a moment. Almost all patients are on this medicine at some point in their disease, and it can be the initial drug that's used, especially if their symptoms are severe. Long-term use can lead to dyskinesia or the inability to perform voluntary movements. So that can be, and that's obviously what you're trying to treat. So that can be kind of a problem. It's important to give these medications before meals so that they're absorbed better. So you want this one given on an empty stomach, and it will go across to the blood-brain barrier. So I'm going to try to change this to, can you see this? Can you see this medication sheet? Okay, good. I don't know what happened before. So this is the one that we're on. It does, levodopa is converted to dopamine in the CNS, where it does serve as a neurotransmitter. The carbidopa prevents the peripheral destruction of the levodopa. So the levodopa, it does mimic the dopamine that is not being used or not being produced. And then
Ms. Shelton?
Yes.
I cannot find this medication sheet on Canvas.
Okay, if it is right here, it is.
Okay, thank you.
See it? Okay. 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 And so the levodopa is the one that helps to actually produce the effects of dopamine, the excess dopamine, and the carbidopa is it keeps the degradation of the levodopa. So we do want to remember the adverse effects. can cause hemorrhage, GI perforation, pancreatitis, depression, and those involuntary movements, and again, orthostatic hypotension and constipation, so it slows down everything, nausea, vomiting, and one thing that's really interesting is it can cause melanoma. So that is something that you'll definitely want to remember. So you do want to remember that a contraindication, if somebody already has melanoma, they obviously don't want to take this, or if they have melanoma, or if they have liver disease. So that's something you want to, or ulcer, or liver disease, but ulcer. Also, you don't want to use this with MAOI drugs. It can cause hypersensitivity reactions. And you don't want to give it with kava-kava. That can decrease the effectiveness of the levodopa. The MAOIs and the kava-kava. It can be given PO and enteral or through tube feedings. So some of the nursing assessments are based on the adverse effects, that kind of thing. We obviously need to watch for all these symptoms. Need to assess their blood pressure. And we also want to assess their pulse throughout the period of dose adjustment. We want to look at their glucose as well. We want to monitor their hepatic function and their renal function. We want to look at their CBC throughout therapy, and may decrease their H&H, causing granulocytosis, anemias, thrombocytopenia, leukocytosis, and an increase in WBCs. And we want to assess for toxicity. And this is the symptoms of toxicity that you'll see: involuntary muscle twitching, facial grimacing, spastic eye movements, winking, protruding tongue. Their tongue will just stick out, go back and forth, and of course any kind of behavioral changes. And the hospital to continue on same therapy as at home. If they are, obviously, if they get, now this can be a problem, and you may have noticed this in your clinicals. Patients are on several medications many times when they come into the hospital. But the hospital is only concerned with the reason why they're there. For example, if somebody comes in and they have to be treated overnight, or admitted for treatment for a kidney stone, for example, they may not necessarily start that patient on their home medications. They may just be giving them anything they need to for the treatment of the kidney stone. And so it's very important that patients that are on maintenance medications of any kind, whether it's this or anything else, that they get these medications when they are in the hospital. Personally, I've learned just to take for my family members and myself, just to take medications that I'm on routinely with me, and if they're not, and just take them. Now, obviously, we're not supposed to do that. What we're supposed to do, if a patient does bring in home medicines, those medicines are usually supposed to be sent to the pharmacy. The pharmacy relabels them and then sends them back up. Now, hopefully, the other thing that's really supposed to happen is that you get a list of all the medications the patient is on. You contact the doctor and make sure that they, get those medications on a regular basis. This, many times, by the time you do all this, for some conditions, are discharged by the time this happens. So it's, it's very important, though, that patients that are on maintenance medications for illnesses, they do get their medications as well. Now, we want to educate the client for the GI effects or the take as directed. The GI effects to take maybe decreased, with foods. And they need to they also need to watch how much protein they have. So you want to remember about protein. They may need to divide their protein up during the day. Because if they take this with, like you have a high protein meal and you take the medication, that can affect the absorption. So protein is important as well. They may experience sudden dizziness or drowsiness. And so it's very important if they change positions slowly. We've talked about this in other medications that causes hypotension. And it's important to monitor their skin for any lesions. Okay, because again, a side effect is melanoma. So that's why it's very important to remember this in relationship to these medications. So the evaluation of this, of course, is that they do get, their symptoms are controlled. They may not completely go away, but they are controlled, and it may take 2 to 3 weeks for them to realize that they do, for the symptoms to start going away. So then the next one that we want to look at is Roxpanol. And I believe I'm starting to make it here. So in group 2, who would like to discuss what are the therapeutic uses of this? This one should be pretty easy.
Decreased tremor and rigidity in Parkinson's disease and decreased leg restlessness.
Yeah, restless leg syndrome. This is a syndrome where the legs are just real restless, especially at night. So yeah, that's exactly right. So it would be management of Parkinson's disease, obviously, and management of restless leg syndrome, as you mentioned. Now, the things that we want to look for are sleep attacks. And sleep attacks are not just some kind of feeling sleepy today. Sleep attacks are, I can't stay awake and I'm going to sleep right now. This is what happens with narcolepsy, but it's an attack that you have an uncontrollable desire to sleep. And so that is a bit different. The other thing that you want to look for, especially in this, is hallucinations. It's very important, as well as, again, melanoma. So obviously these people should stay out of the sun, and if they have if they're having melanoma or any problems with that, or even a strong family history, I would kind of question about using this sort of drug. We do want to, some contraindications would be a major psychiatric disorder, or psychotic disorder, I mean. Use cautiously with renal impairment, and they may have to adjust dosing for this drug. And apparently there's no food-drug interactions. Isn't that nice? And there are, it is given PO. So now, what were some of the nursing interventions based on some of these adverse effects and contraindications that group 2 found for us?
It says for signs and symptoms of psychotic-like behavior.
Okay. And
monitor.
I'm sorry, go ahead. Go ahead, I'm sorry.
Okay. Monitor ECG and BP frequently and throughout therapy. Assess patient for drowsiness and sleep attacks. Assess for signs of Parkinson's and restless legs.
Marianne, could you say that again? Thank you.
Yeah, do you need all of it, Hesham, or just some of it?
Just like all of it.
Okay. So assess signs and symptoms of psychotic-like behavior. Those risks increase with age. Monitor ECG, and BP frequently and throughout therapy. Assess patient for drowsiness and sleep attacks. Assess for signs and symptoms of Parkinson's and restless leg syndrome. Do you need me to repeat anything, Hesham?
No, I'm good, thank you.
You're welcome.
Any other questions about the nursing interventions? Okay. And so who else in group 2 wants to talk about the client education? Have you Marianne or Kate?
Don't you want to change positions slowly and assess skin frequently?
Okay.
Notify if pregnant or suspected to become pregnant.
I'm sorry, what was the last thing you said?
Notify the healthcare provider if you're pregnant or plan to be pregnant.
Okay, right. Okay, so we want, again, if they start having, what about, did you mention, I may not have missed this, about the sleep attacks?
No, but you want to tell them that it may cause drowsiness and unexpected episodes of falling asleep.
So you want to notify the doctor you start having the sleep attacks and explain to them what it is, that it's an uncontrollable desire to sleep, as well as just being more sleepy. We need to talk about pregnancy. We don't really want them to, be pregnant with this. Change positions slowly because of, the changing blood pressure and skin, and have their skin affected. Yeah. So
Is the skin, Mrs. Strong, what do you say about the skin?
Well, they have they're more likely they're melanoma or skin cancer.
Oh, okay.
For this medication, so we want to assess for that. So we want to look for any, oddly shaped, like brown skin lesions, oddly shaped moles, maybe, that kind of thing.
Okay. And you say about the sleep attack is just or sleep?
Well, it's like I'm sitting here, we're in this class. I mean, you may have been experiencing this right now, but an uncontrollable desire to sleep is what sleep attacks are. It's more than being sleepy. We have your, if you don't get much sleep last night, you're kind of sleepy today a little bit. That's part of it, but they also can get sleep attacks, which means that they have to sleep.
Oh,
not an option.
I'm sore.
Okay.
Same. Okay, I'm glad you're sore too.
Okay.
Oh. So does that make sense?
Yes.
Okay.
Murphy, we could hear you.
Yeah, I'm Murphy.
Oh, you can hear me? Oh.
Sam.
Sorry guys. My bad. Okay. Sorry.
Well, that's just part of the fun of this, dogs barking, talking to people, emptying dishwashers while you're in class, just all sorts of things. That's all right. That just makes it more fun.
I forget, Murphy.
Yeah.
You guys won't happen again. I was just talking to my roommate. It's fine.
That's okay. So obviously, we want their symptoms of Parkinson's and restless leg syndrome to be relieved from this. So but you're seeing kind of some patterns of these drugs as well. So that's part of it as well. So we go back to this page. I don't know where that came from. Okay, our little fact sheet. Now we have COMT inhibitors and enzymes. This is just anytime you see the ASE, that generally means an enzyme. So these are enzymes that inhibit dopamine. So we don't want them around. So the inhibitor blocks the enzyme and prolongs the action of levodopa. And this is an example. Capone is an example that is used sometimes used in combination with levodopa.
Ms. Strong, would you repeat the therapeutic uses, please? It break up when you were talking about it.
This drug right here, I didn't understand.
Pramipizole. The therapeutic use, please.
It
break when you were talking.
Oh, I'm sorry. This is an enzyme, and ASE again usually indicates that that's an enzyme that, that just in general. And these enzymes inactivate dopamine. So dopamine is what we need to control Parkinson's. That's the whole point, is we don't have enough dopamine on board. So this drug right here is an inhibitor that blocks this enzyme. So that actually prolongs the effects of levodopa, which actually does then, levodopa mimics the action of dopamine. So it prolongs those actions and makes them last longer. Does that make sense?
Yeah, thank you.
Monoamine oxidase type B inhibitors. These are the most popular drugs for patients with mild or early symptoms. They slow the main type B of monoamine oxidase in the brain, so it increases dopamine, in other words, and reduces the degree of symptoms. It also can protect the neurons in the brain, and we had through that video, we showed how the neurons were affected in Parkinson's disease. And so this drug, rosylene mesylate, can be used alone or with levodopa. And what you want to remember about this drug is that it decreases the freezing episodes. Many times people with dopamine with Parkinson's will kind of freeze in place almost, and they can't move, or move their hand, or their hand just stops if they're trying to go pick up something. So this will help relieve those episodes. Make sure that's what I'm saying. So then we also use anticholinergics for severe motor symptoms such as rigidity and tremors that one can get. It's rarely used the primary choice of drug due to side effects. It's avoided in older adults because of the cholinergic or anticholinergic actions of the drug. And we know essentially what this drug does is dry people up. It can cause confusion, but it causes urinary retention, constipation, dry mouth, and blurred vision. So that's just a review of the anticholinergic effects. And this is the medication. So you will want to remember what I have highlighted right here. Okay. And so that is the drug that would be used for that. But again, it's not used very often, as you can imagine.
We can't see what you have highlighted. Am I the only one?
No, I can't see it either.
Oh, I'm sorry. Well,
yeah, which drug are we on?
Yeah, I don't know which drug we're on.
Can you see the page I'm on right now?
Right now, yeah, go ahead.
Pramipizole.
Yes.
Pramipizole.
I'm sorry. Excuse me. Can you see this fact page?
No, we are in pramipizole. We are still in the last drug, so
We just see the PI page for Prami.
Can you see the fact page?
No.
Okay. I'm so sorry.
No.
no, Olivia.
Now can you see it?
Yeah.
That's the back page, yeah.
Okay, so you didn't get any of that I said before, did you?
No.
Okay, I'm so sorry. I didn't realize you couldn't see it. I don't understand this. So when I go from thing to thing, I guess I have to do that. I don't know where we were. So this is what I was talking about the enzyme inhibitor. When you have an ASE, this is the usually means an enzyme, and these enzymes inactivate dopamine. So that means that it will block, the effects of levodopa. So if we use this medication, entacapone, it actually will interfere with this enzyme. It's an inhibitor. So you'll want to remember this drug here. Can you see that now? Okay.
Yeah.
Yeah. Okay. I'm so sorry. Thank you for telling me. This is a glitch that I didn't anticipate. Okay, because I've had this before. Now, these are monoamine oxidase type B inhibitors. They're usually used early onset of Parkinson's. And what they do is they increase the dopamine concentrations in the brain, and of course, so that will help with decreasing the symptoms. It also can protect the neurons in the brain, and you saw the video about how the neurons were affected. And this is the medication that you'll need to remember related to this, and it does decreases the freezing episodes. Someone with Parkinson's may reach for something and they'll just freeze, and they can't quite go all the way to get it. So this is the medication that actually will help with that. You want to remember that.
Ms. Armstrong, we don't have any tempo on
No, there's
this.
not. That's all you need to know. No, you don't.
Oh, okay. All right.
Yep. Trust me. I'll let you know what you need to know. Yep. No, you don't. And some of these drugs in here you don't have. This one, no, you didn't have either. I think the purpose is to give the drug or the templates for those that are extreme, the very, very common ones that you're going to see. Now, anticholinergics, as you know, sometimes can help with the severe motor symptoms, such as the tremor and rigidity. They are rarely used because they, especially in older individuals, because they do cause, the anticholinergic side effects, and which are the things I just highlighted. Essentially it dries people up. Urinary retention, constipation, dry mouth, blurred vision, and especially in older individuals may lead to confusion. And so this is a medication that could cause that. That's the anticholinergic that would be used if one is going to use that. However, it's not used very often, but you will need to remember that one. Okay. All right. So, I'm going to go back to share, and I will go to okay. Now, can you see the screen with the videos on it?
Yes.
Okay. This is your last video. It does deal with dementia and Alzheimer's.
Dementia is a word we give to a set of symptoms affecting different aspects of thinking and brain function. These words over time affect the quality of our lives. Dementia is not a normal part of aging. It is the result of physical diseases that damage the brain. Everything that makes us who we are, our personalities, intelligence, emotions, our hopes and our fears are driven by this incredible organ. The brain is the most complex organ known to humans. Networks of brain cells, bundles of nerve fibers, hundreds of miles of blood vessels all work in careful unison to keep us beating every day. Every second of our lives, nerve cells in the brain are firing. But when these cells become damaged and their connections start to break down, that develop dementia. The area of the brain where this damage occurs determines the symptoms a person experiences. If nerve cells in the back of the brain are damaged, the person person's vision might be affected and they may have trouble reading words or climbing stairs. If nerve cells in the side of the brain are damaged, communication and language skills can change. There are 4 main diseases of dementia. Symptoms of these can overlap sometimes. While each disease has characteristic symptoms, these can change from person to person depending on the serious domain the disease is affecting. Alzheimer's disease is the most common cause of dementia. Often, the first areas of the brain to be affected by Alzheimer's is the hippocampus. The hippocampus controls aspects of our memory and navigation, so forgetfulness and also usually some of the first symptoms of Alzheimer's. In Alzheimer's, nerve cells are damaged by a buildup of 2 proteins in the brain, amyloid and tau. These proteins are present in all of our brains, but in Alzheimer's they behave unusually and begin to clump together. Researchers are still trying to understand what triggers this, but it's likely to be a mix of age, genetics, and other factors such as poor heart health. The buildup of harmful proteins is also a key factor in other diseases behind dementia, like dementia with Lewy bodies and frontotemporal dementia. This damage spreads from one area of the brain to another as the condition progresses. So symptoms get worse over time and people begin to find more aspects of day-to-day life difficult. Dementia with Lewy bodies can affect different areas of the brain, leading to a variety of symptoms including pains and function, sleep problems, and hallucinations. Processes involved in dementia with Lewy bodies are similar to those involved in Parkinson's disease, and people with dementia with Lewy bodies can also develop Parkinson's-like symptoms such as shaking and slow movement. Vascular dementia can occur after someone has had a stroke or the blood vessels in their brain are in poor health, while the other diseases that cause dementia spread steadily through the brain over time. Vascular dementia can progress in distinct steps after an event such as a stroke, slowing a person's ability to think, plan, and pay attention. Fortunately, there is currently no cure for any of the diseases that cause dementia, and no treatments that can slow or stop the spread of these diseases through the brain. Researchers all over the world are looking for new ways to tackle these diseases and protect precious nerve cells. Their work has the power to offer new hope to millions of individuals and families whose lives are affected by dementia. To find out more, search Alzheimer's Research UK.
Okay, can you see this fact sheet now? Okay, thank you. So, dementia is a very tragic disease, and it does affect people differently. You may have had family members that have had this illness. It's been referred to as the long goodbye, because by the time someone gets to the end of this illness, you've actually lost, like my grandmother had this. I lost her a long time before she died, and so it's very sad to see someone who you know and love who doesn't know who you are. The other aspect of dementia that can come into play is also people can become very aggressive. And that's when it's very difficult for family members to keep someone with dementia inside their home because of this aggressiveness. It does get worse at night many times. It is called sundown syndrome. Usually in the evening is when it actually gets worse than in the morning. They have periods of complete cognitive ability. They're alert, oriented, everything's just like you and I would be right now. And then later they may not again know who someone is, may not know what year it is. I will share one interesting thing. When my grandmother, the last day or so of her life, I was with her, and I talked to her, and she thought it was like 1950, and there were some people in her living room, and she could remember distinctly what everybody was talking about and who was there. And also, just probably within a couple of hours of her death, she became completely oriented, completely alert, and we shared that moment together. And so I thought that's just a gift that God gave us. But it is very difficult if you have family members dealing with someone with Alzheimer's. It's difficult because it is gradual. The person with dementia, I think, I don't know what how it is experienced from their point of view. They may not realize that they have it, and probably there's a lot of denial involved. And I think that leads to some of the anger that you may see. But it is chronic and progressive. It does affect the ability of the person to learn new things, impairs language, judgment, behavior. And the medications, treatment of cholinesterase inhibitors is used for treating it. It is approved for treating, these symptoms. It's an approved cholinergic neurotransmission in the brain by delaying the destruction of acetylcholine by acetylcholinesterase. That's an enzyme. Slows cognitive decline, does not alter course of the disease. Nothing is going to change the disease. There's some drugs that they say might slow it down somewhat, but it's going to keep moving on. You will want to, this is the drug that we want to look at right now, donepezil, and we do have a template for that, and I will go to that. I have to get it done. So we want to go back to this one, and this is the student PDF that. Now, can you see this mid sheet? Okay, thank you. Thank you. So this is an anti-Alzheimer's agent or a cholinesterase inhibitor. It does inhibit the cholinesterase that improves the cholinergic function by making more cholinesterase available. It is used for mild, moderate, and severe dementia, neurocognitive disorders associated with Alzheimer's disease. Now, what were some of the adverse effects that Group 3 had? And this is Heidi, Sarah, AZ, Luce.
I have a headache, headaches, abnormal dreams, depression, dizziness, drowsiness, fatigue, insomnia, syncope, sedation, AFib, hypertension, hypotension, diarrhea, nausea, vomiting, anorexia, weight gain, frequent urination.
Okay. Okay. Thank you. I appreciate that. That's very thorough. The other things you might want to think about too is atrial fibrillation can be caused by this, as well as ecchymosis. So you're going to have a lot of bruising, that kind of thing, and bradycardia. So those are, some of the, as well as the things that she mentioned. So it's important to use constantly for those that have any underlying cardiac disease or a history of seizures. That would be obviously a problem that you would not want to use this medication related to that. And what food or drug interactions did anybody find in that group?
Let me see.
I just have one. I'm sorry.
Like second choline.
Jimson weed, is that what you're saying?
Starts with SUCCIN YL choline.
Oh, can you spell that again?
SUCCIN YL and then choline.
Okay, sexacholine. Okay, that is something that may cause some paralysis. The other thing that we need to watch out for is that ginseweed may antagonize of the drug. So you don't want to give it with ginseng weed either. I'm learning all about these types of drugs. So succinylcholine and ginseng weed are things that you want to avoid with this med. It is given orally. And what are some nursing interventions that we want to look at?
Assess cognitive function.
Okay.
Monitor heart rate.
Okay. All right. Yep. And we want to take this in the evening, right before bed. And we also, apparently, it's we don't want to crush it or break it into for the high strength tablets. So you want to remember as well. So we want to take it daily as directed at the same time, and it should be taken in the evening. It may take several weeks before this one is actually, again, if they see any effects. And people, if they don't get effects within the first pill or two, they think it's not working. So tell them it may take 2 or 3 weeks. The medication can cause dizziness, and you do, of course, obviously need to tell the doctors if there's any problems with this. They said we do want improvement of their Alzheimer's symptoms would be what would be that we would look at. Now, the other template that we want to look at is this one. Can you all see that one? Okay. Can you see it? Okay. And so this was the last group. What were the therapeutic uses for this one?
It's anti-Alzheimer.
I'm sorry?
Anti-Alzheimer. Agents from, it's cholinergic. Let me see.
What would we use?
Maybe I'm wrong. I said anti-Alzheimer agent.
Okay.
Oh no, never mind. That's
sorry.
I think I could get wrong information. That's a action classification. Sorry.
Treatment of moderate to severe confusion related to Alzheimer's.
Okay. Okay. Very good. And so the first effects, let's see, would be, of course, dizziness, headache. You want to remember that it will cause hypertension, and also anemia. So those are the 2 biggies that you want to take away from the adverse effects. And what are the 2 contraindications for this drug?
We said renal and severe renal impairment and severe hepatic impairment.
Right, renal and hepatic impairment. So you do want to, that's true of most of these drugs. And so these drugs can increase urine pH. So if the person is taking sodium bicarbonate or something that does that, it may decrease the excretion and increase blood levels of that. So you want to be aware of that. Also PO intake. Some medications that may increase urine pH, it would be contraindicated. So what kind of nursing interventions do you think we should do with this?
You want to assess cognitive function.
Uh-huh.
You want to do some blood work to test for renal function. That could be BUN, creatinine.
Okay.
Liver function test to test out see if there's any hepatic impairment.
Uh-huh.
And then the CBC can help you with anemia, as well as looking at platelet counts from the hepatic impairment.
Okay, very good. Yeah, that's just very good. So obviously, if it can affect the liver, if this is a problem, then we need to watch for that as well. Very good. And due to the anemia, we want to look at the CBC. So yeah, that's great. Also, we can give this with or without food. And we also want to, you know, don't don't, you know, split the pill or anything. And remember, unless the pill is actually scored, you really need to look it up to see if if you can do that, because generally you can't if it's not scored. So client education, we want to instruct the patient and caregiver how to give it. And sometimes doses need to be titrated. We want to watch out for any dizziness. It's important. And we want to teach the patient that cognitive improvement may take months to actually improve, and it's not going to be reversed. If they've reached a certain point of dementia, we're not going to get better from that. We may just help, I think, just maybe help not progress maybe quite as fast. So the effectiveness of the medication, of course, is that they do have more memory, attention, reasoning, language ability. So, you know, just the symptoms of dementia. Okay. I'm going to go back to okay. Can you see this? Thank you. So, last we talked about is an NMDA receptor antagonist. And overexcitement of these receptors by the neurotransmitter glutamate may play a role in dementia, Alzheimer's. These drugs block excess amounts of glutamate that can damage nerve cells. Also, it's indicated for advanced disease. It may just slow the progression. It won't really, you know, cure them. May help patients maintain function longer, and can be given with the other medication, donepezil. So that's basically the didactic that, you know, we're going to go through today for right now for this. So what I'd like to do is make sure. Does anybody have any questions? Want me to go over anything else on that? Okay. Just as a reminder, because it's been a while, I thought it might be a good idea for us to actually do, I'm just going to go over a few points. I'm sorry. Okay. I'm just going to go over a few points, you might about, you know, the next test 4, since it's been a while since we've been over that, although, you know, some people did take that. But just some things that you might want to review or go over or think about for the test for next week is just look at you know, the drug used for athlete's foot is an antifungal called ketonazole. I'm sorry, KETOCONAZOLE, ketonazole. And
Ketoconazole?
Yes, ketoconazole. And this medication is used, you know, it's an antifungal. And just kind of look and see, like, how long does it take it to react? You know, look at some of the parameters, some of the patient teaching that you would do with that medication. Okay. And what is the normal creatinine level in adults?
0.8 to 1.2.
Right. Some labs is 0.6, but yeah, you're in the ballpark. If you know that, that's fine. 0.6 to 8 to 1.2. So you need to be, you know, you'll need to know the normal creatinine level. Now, can you treat viruses with antibiotics? No. So if somebody has a virus, they can't be. We do antivirals. medications. Acyclovir is one of those antiviral medications that can be used to help reduce some of the symptoms of people that develop viral conditions. And, these can be, chicken pox or measles or, anything that's considered a viral infection. Now, can any nurse give IV chemotherapy? No, it has to be a specific, right. You're exactly right. It has to be a specific, chemo nurse who's been trained and hopefully certified in that as well. I think most of that. And know what makes up the personal protective equipment, like the gloves and the gowns, that kind of thing. So make sure that you know what that is as well. Now we, I don't know if you can remember this, but we did discuss methotrexate, the medication that's used. What is one of the major side effects or adverse effects of methotrexate that we would want to assess for?
Pulmonary fibrosis?
Yes, pulmonary fibrosis. And so if they have a dry cough, that sounds familiar, that it does, that would be a sign of that. That's strangely also a sign of the coronavirus. It's a dry cough because it affects the alveoli of the lungs itself. Rather than producing sputum, it causes this dry cough because it's actually damaging the lungs down to the cellular level. But that's a different topic. So if you're giving a PO drug, a chemotherapeutic chemo drug by mouth to a patient, do you still have to wear the PPE equipment?
Yes.
Yes, you do. Yes, you do. Yes, thank you. Now, one thing that, and this is something I think when I reviewed this before, I wasn't sure it had gotten into the content, was if someone is trying to prevent osteoporosis, one thing you might want to consider suggesting to them is to take a 1-a-day multivitamin because it does have some calcium in it and some vitamin D, which helps the absorption of calcium. So, we talked about all the fancy drugs, but sometimes even just a multivitamin will be helpful for them as well. Now, we also spoke about open-angle glaucoma. Now, the medications that we discussed about open-angle glaucoma that we give for that, is it going to reverse it or just keep it from getting worse?
Just keep it getting worse, right?
Exactly.
Worse.
Yeah, it's just going to keep it from getting worse. It's not going to really, make anything better. That's the tragedy of that, unfortunately. Now, if you do have someone that is getting chemotherapy, an oncology patient, what is one of the first things that we want them to report? What is a major thing? We do a lot of patient education, but one thing we really want them to tell us if this occurs, like at home, in hospital.
Is it fever?
Fever, exactly. Who said that?
Olivia.
Well, hi, Olivia. I'm looking, it's kind of hard to see. Yeah, exactly, fever. And it doesn't have to be a high fever either. We're talking about even 1 degree or a little bit above. It does not, but because that's the first sign of infection, the immunocompromised, they're going to show infection much more quickly than we are. So, or a person that's not immunocompromised. So that is very important. Very good. Also, we'll need to know, what is the normal calcium level?
9 to 10.5.
Okay. Some labs use 8.6, but yeah, you're in the
No.
ballpark. Yeah, you're in the ballpark. Yeah.
9, not 6. Is it 6?
I said 8.6, so that's almost.
Oh, 8.
Yeah.
Okay.
For some labs, but yeah, that's fine. If you know that, then that's fine. Yeah, just remember that. Now, remember that the DXA scan is a bone density scan. So just remember that. And that's always a scan to determine if someone has osteoporosis. So, and, you know, we have, there's a few medications that we do give for that. And one is this aldronate. And anyway, medications that we use for osteoporosis, what is one of the really major things that they have to watch out for that's a really big problem with these drugs?
Kidney?
Possibly, but it's the GI upset. It causes them a lot of a gastric reflux. They need to sit up for 30 minutes after they take it. If they already have gastric reflux, they probably may not want to be taking these medications. But reflux disease is it's a really big problem that they can have with these drugs. So they do need to sit up for 30 minutes after they take them. So chest discomfort is, would be something they'd want to report. And the problem with chest discomfort is, even if you kind of know that it's probably the drug, it's a GI problem, you never really know until you do an EKG. So, yeah. They also, what other symptoms do you get with gastric reflux? Like, like heartburn and difficulty swallowing, and also coughing, strangely enough. I'll be familiar, anticholinergic effects on the body, so be familiar with that. Just think of something that's going to dry someone up, and if it's not that, so just be familiar with those. And another common characteristics of Meniere's disease. And what are those three things?
Dizziness, nausea, vomiting.
And tendinitis, vertigo, and like it's only on one side.
Exactly.
Yeah.
Yeah, the vertigo. Yeah, when someone says they have dizziness, you need to differentiate between vertigo and just like they see spots and are about to pass out, because they'll just say they feel dizzy. And if anybody's ever experienced severe vertigo, it can be very severe at times. So, but yeah, that's exactly what it is. Now, promethazine, that's an antiemetic we give for nausea, vomiting. And what is the problem with giving it at IV?
Infiltration.
Yeah, what happens if that happens?
Yeah, skin breakdown.
Yeah, it destroys the muscles and skin. Yeah, it's pretty bad. And we also, if you do give it, make sure it's very highly diluted. Now, if you're giving, and this is true, if you're giving eye drops to someone and you're giving, say, 2 different eye drops, eye drop A, eye drop B, how long should you wait between those eye drops, giving those eye drops?
15 minutes.
I'm sorry?
10 to 15 minutes?
5 minutes.
So around 5 minutes, anywhere from at least 2 to 3 minutes, or else you're just washing it out. I think it is 5 minutes too, but you'll want to remember 2 to 3 minutes. But if you're in practice, it should be 5 minutes. And, we give pilocarpine to people with glaucoma. We want that medication to stay in the eye itself. We don't want it to be absorbed in the ducts and go systemically. Right? Remember that?
Yeah.
And so we want to, apply the pressure here so that it doesn't go into the systemically. Now, review what happens when someone has a skin infection. One of the main signs, or a very severe sign, that it's become systemic. Now, if you're giving somebody a medication, if you've been ordered to give somebody a medication and they've listed these as one of their allergies, what would you do?
Don't give it.
Right. Don't give it and tell the doctor. Right. And sometimes they forget that. And it's very important to always double check, their allergies before you administer the medication. Kind of look at the contraindications for effing, and it's RALOXIFENE.
Which one is it, Miss Sastra? I couldn't hear you.
RALOXIFENE. Know the contraindications for those. If someone did have a high calcium level, what might be a side effect of that? What condition might they develop?
Cardiac?
Anemia. Calcemia, whatever.
Y'all, is there anybody ever had a kidney stone?
Yeah, kidney stone.
Yeah, kidney stones too. Yeah, you don't forget that. Now, if we give a medication through the spinal cord, what clinical sign are we going to assess them for?
Headache.
Okay. What else?
Nuchal rigidity.
Right, nuchal rigidity. Can they touch their chin to their chest? Stiff. So yeah, we want to check, their nuchal rigidity as well. Okay, sometimes if we're giving somebody a drug, and sometimes even if before we give a blood transfusion, we will give pre-medications to help deal with the signs and symptoms of an allergic reactions or just inflammation. And so, some of these medications we might give a steroid before. We might give Benadryl or diphenhydramine or acetaminophen, but those are the kind of things that we might give prior to administering those medications. Now, if somebody is taking a medication for osteoporosis, what's one of the long-term side effects that they might experience? Yeah, I think y'all know this. Look that up. It is osteonecrosis or long bone fractures. Fractures of the long bone. So kind of review that. And remember that weight-bearing exercises are effective for increasing the absorption of calcium into the bone. So it's going to strengthen the bone as well. If we're giving a beta blocker to someone, one of the things that we do is check the heart rate. And at what point would we hold the medicine or tell them to hold the medicine? What rate?
Less than 60. 60
is the magic number. In reality, the doctors may say, it's okay to be in the 50s, but you want to remember that it would be around 60. Okay, and I know you've had this before. Peak and trough. When do we draw the blood sample for the trough? Yeah, right before the medicine's given. When would we do the peak?
30 minutes.
After it's in peak.
After.
Yeah. It may take 30 minutes for it to go in, so then you do 30 minutes after that. Or sometimes it might be now between 30 minutes and an hour after that, right? You might want to review the some of the effects of doxycycline. If somebody has a very mild skin condition, like psoriasis, that kind of thing, what topical medication might be recommended for that?
Hydrocortisone?
Yeah, like the cortisone, yeah, exactly. a corticosteroid, right? Now, if you're given, this is true of any medication, there's a specific one here, but if you're given a medication IV and the patient starts talking about burning problems, what should you do?
Stop the infusion.
Yeah, stop the infusion. And actually then, yeah, stop the infusion, exactly. Now, we talked about people who were think about asthma for a minute. We have medications used for acute exacerbations, and then, other, or a rescue inhaler, and then those used just for long-term. What is an example of one that's used for a rescue inhaler or for acute exacerbation?
Albuterol.
Albuterol.
Genius.
Yep. Now, we have someone who has an infection, even urinary tract infection or skin infection, and we're probably going to go ahead and start antibiotics. But before we start antibiotics, what would we do? What kind of test would we do?
Urinalysis?
Kidney, liver.
No,
okay.
Sensitivity. Okay.
I come in with a UTI into your clinic.
Urine analysis.
Okay, you're going to do your analysis, and what else?
Specific gravity.
And sensitivity.
Sensitivity.
Culture
sensitivity. Okay.
Exactly. Your analysis is going to tell me if we have an infection or not. The culture sensitivity is, it does a culture to see what organism grows out, and then the sensitivity will indicate which antibiotic will kill that bacteria. So you're going to start them on something, or they're going to be started on some kind of antibiotic. But when the culture and sensitivity comes back about 3 days later, then we're going to know if we need to change or not, because it will show specifically what will kill that organism. So that's why if they have a UTI, a urinary tract infection, that sample needs to be sent for culture and sensitivity. And this is true of if you have an infection of skin or anywhere else, you want to do the same thing. That occlusion thing I talked about is called related to medication given for open angle glaucoma, where we put the pressure here. You'll want to be able to describe that. Okay, it's got punctal occlusion, P-U-N-C-T-A-L, occlusion, P-U-N-C-T-A-L. And so you're going to want to be able to explain that.
Like explain how we would do it?
Yeah, how would you tell the patient to do it?
Okay.
Because they're going to be doing it at home. So how would you educate the patient how to do that? Okay. So I have other little thing we can do, but I think that we've been through enough probably today. Are there any questions?
I have a question. So next week, I know we have our test. Then do we have class after?
Yes.
Okay. What time is the test again?
9 o'clock.
Okay.
My time. I don't know where you are, Murphy. Are you?
Yeah, I'm in Colorado. So me and Becca, that'll be 7 and 6 for Becca, I think.
6?
For Becca, yeah.
Becca, yeah. I'm sorry. Well, I mean, we could talk for a while and then do it, I suppose. But
No, it's okay. It's okay. I don't mind doing it.
I had to do it first, and I'm sorry for this. And we've discussed, because some people are, like in California, that's 4 hours, right?
3.
3. Okay. I'm sorry about this, but you do have a class after this, so I can't really. I'm sorry about that.
No, that's totally fine. I don't mind.
Well, I take classes online from University of New Mexico, and I have to read. They're 2 hours. I'm 2 hours ahead, so it's sort of my benefit. But so I have to do things later than that normally you would think. But so I apologize for that. But you're used to clinical, so you're used to getting up in the middle of the night and going somewhere. So it's kind of and a minute. I want to show you something.
I hope it's her dog.
This is the dog that's been causing all this problem.
Oh, it's so cute.
It's Abby, and she's a cute little thing, but when she hears anything, she starts barking. I do with Gardner around my appointment, and she was supposed to be a miniature dachshund, but she's, not. So she's not a standard either. But we love her, and she's cute, but most of the things I do around here is in the morning. This is when I have these classes, and so and if I put her in a different room, that makes it worse because then she misses me. So here she is. She's the cause of all the trouble. Say hello, Abby. Yep.
Yeah.
These are the people that you're bothering. Okay. If you have any questions, please let me know. What's your dog's name, Murphy?
My dog's Billy. Her name's Billy.
Oh, hi, Billy.
Can you say hi, Bill? She's big. She's not a lap dog.
Oh my goodness, so cute. What breed is it?
It's a Bernie Doodle.
Oh my gosh, so cute. I love it.
My dog's cuter, Murphy.
What'd you say?
My dog's cuter.
No, look at
Your dog, Ryan.
This is my roommate's dog.
Oh, how cute. Look at those ears. Oh, it's so cute. Now, see, this isn't something we could do in the classroom. Isn't this nice? Okay. Well, I will let you guys go. And if you don't have a pet, you should get a pet because they're very helpful. So you guys take care. Let me know if you have any questions, and I will post this in the course.
Wait, one more thing. Is the test on Zoom?
No. Well, I mean, the test is going to be in the course.
Oh, yeah. All right, forget that.
We'll have to have Zoom on your phone. It's going to be weird, but you're going to go through it Monday, so by Friday you should know how to do it.
Okay.
Okay, same procedure.
Okay.
Okay, and then we'll have a Zoom meeting afterwards. So I will try to record this.
Okay.
Okay, or post it. Okay, thank you. See you all.